Welcome back to the deep dive. Today isn't just another exploration of a topic. We are shifting gears. We're entering some pretty high-stakes territory. I want you to imagine the lights are bright, the air conditioning is humming a bit too loudly, your palms are sweating, and you are standing in front of a senior professor.
Okay.
And he's looking at you over the top of his spectacles.
That is a very specific, and I have to say, a universally terrifying visualization for any medical resident.
It is, because today we are treating this deep dive as a dedicated exam preparation session. Specifically, we're simulating the Gujarat University MD Anesthesiology exam preparation.
Right.
So for today, I am the resident, I'm the learner, the one on the hot seat, and you.
I'm the senior faculty, the examiner conducting this mock Viva.
I see. So the pressure is entirely on me to perform.
And my job is to grill you on the details to make sure you're ready.
Exactly. My entire medical career, or at least my degree, is on the line here. And the topic you have chosen for me today, it is the ultimate emergency, the absolute nightmare scenario. We are talking about cricothyrotomy.
It's the procedure that every anesthesiologist prays they never have to do.
But must know how to do perfectly.
Absolutely. If you are sitting for your MB exams, this is not just a technical skill. It is a goldmine for theory questions, for short notes, and for those breaded Viva stations.
So our mission today is really twofold. First, we need to decode that clinical nightmare of cannot intubate, cannot oxygenate, or CICO.
The big one.
But secondly, and this is for you, our listener who's prepping for that exam, we need to provide the exact keywords, the structure, and the examiner-safe answers that will get you high marks.
Examiner-safe. That is the key phrase there. In an exam, and even more so in a crisis, you want clarity. You want standard textbooks backing you up.
Right.
You don't want to be quoting some blog post you read. You want to be quoting the Bible of anesthesia.
Speaking of Bibles, I have pulled a massive stack for this deep dive. We are looking at the heavy hitters, Miller's Anesthesia, Morgan McKyle, the ICU book by Marino, and for the surgical details, B.D. Sharesh's Anatomy.
All good choices. Solid.
And also some practical guides like long and short cases in anesthesiology. We're going to filter out the noise and just stick to what the books say.
Excellent. Let's begin then. Resident, defined cricothyrotomy for me.
Okay, putting on my exam face. Cricothyrotomy is an emergency invasive airway access technique. It's performed through the cricothyroid membrane, or CTM.
Okay.
It's distinct from a tracheostomy in that it's higher up in the neck, and it's intended primarily as a rescue measure.
That is a solid start. A very solid start. But let's refine that for the exam. Miller's anesthesia makes a very specific distinction that examiners absolutely love to hear.
Okay.
It emphasizes that this is a rescue technique, not a permanent airway. That is a critical nuance.
So I should use the word rescue.
You must. If you call it a surgical airway without qualifying it as a rescue bridge, you might lose marks. It shows you don't appreciate its temporary nature. Now, differentiated immediately from a tracheostomy, why aren't we just doing a tracheostomy in the emergency room?
Right. So a tracheostomy it's usually an elective procedure. It's performed lower down, typically between the second and fourth tracheal rings. And it takes longer, maybe 15 to 30 minutes in a controlled setting because you have to dissect through more tissue. You'd have to move the thyroid isthmus, manage bleeding.
Whereas a
cricothyrotomy is emergent. It's done higher up at the CTM, which is superficial. It needs to be done in seconds to minutes, not tens of minutes.
Correct. So here's a phrase for you to remember. Cricothyrotomy is for resuscitation. Tracheostomy is for maintenance.
I like that. Resuscitation versus maintenance.
That is the fundamental divide. So where does this fit in the grand scheme of airway management?
It's the final step. It's the end of the line. It's indicated in the cannot intubate, cannot oxygenate scenario, the CICO scenario. It bridges the gap between a failed airway and a definitive surgical airway, like a tracheostomy.
Exactly. Now, before we get into the blood and guts of the procedure, keep in mind how this appears in the exam paper.
Right.
You might get a short note simply titled Needle versus Surgical Cricothyrotomy. Or you could get a massive 20-mark long question. Describe the anatomy of the larynx relevant to cricothyrotomy and the steps of the Scalpel-Bougie technique.
And in the Viva, they might just point to a mannequin and say, show me the membrane.
Or draw the surface anatomy on your own neck.
Oh, wow.
Which brings us to part B, the anatomy. You absolutely cannot pass this section without anatomical precision. If you are holding a scalpel over a patient's neck, you better know what is under the skin.
Definitely.
So walk me through the surface anatomy. How do you find the spot? Let's say you're in that emergency.
Okay, visualizing the neck, I'm walking my finger down the midline. The first hard structure I'd hit is the hyoid bone, but coming down further, I feel the Adam's apple.
Which is?
That's a laryngeal prominence of the thyroid cartilage.
Good. Stop there. Now keep moving down.
Okay, so below the thyroid cartilage, there's a soft depression. That's the dip. And immediately below that dip is a hard ring.
A very firm ring.
That's the cricoid cartilage.
Right. And anatomy for anesthetists places the cricoid cartilage at what vertebral level? It's a classic MCQ fact.
C6. Level of the C6 vertebra.
Correct. So your target is that dip, that soft spot between the thyroid and cricoid cartilages. That is the cricothyroid membrane.
It feels really small. When you actually palpate it on yourself, it's not a big window at all.
It is small, and you should be palpating it on yourself right now as you listen.
Yeah.
OH's intensive care manual gives us the dimensions. It's approximately 9 millimeters high vertically and about 30 millimeters wide.
9 millimeters, that is not a lot of room for error when you're stressed and the sats are dropping.
Not at all. And according to BD Charesia, the membrane itself is described as yellow, elastic, and relatively avascular.
That relatively avascular part sounds promising.
It is promising, but the word relatively is doing a lot of heavy lifting in that sentence.
Ah.
What are the relations? What are the structures you were terrified of hitting when you make that cut?
Well, the vessels.
Yep.
Definitely the vessels. The cricothyroid arteries, which run horizontally across the upper part of the membrane.
Which means, clinically, what does that mean for your technique?
It means I have to stay low, make my incision or puncture in the lower half of the membrane to avoid those arteries.
Precisely. Let's dig a little deeper into those vessels, because this is the kind of detail that separates a pass from a distinction. The cricothyroid arteries are usually branches of the superior thyroid artery.
Okay.
In anastomose, they join together right across the upper part of the membrane. So if you cut high, right under the thyroid cartilage, you are slicing directly through that arterial arch.
And that's arterial bleeding, which in an airway emergency is just a complete disaster. It would obscure your view instantly.
Correct. Blood sprays into the field, or, even worse, down into the trachea. That is why the recommendation is always the lower third of the membrane. You are using anatomy to buy yourself safety.
So it's not just stay low, it's stay in the lower third. That's the exam-safe answer.
That's the answer that gets you the marks. What about veins? We know the jugulars are lateral, but are there any veins directly over the membrane?
The anterior jugular veins run vertically, but they're usually lateral to the midline, aren't they?
They are, but there can be communicating veins, anatomical variants. But the bigger venous risk is actually hitting the inferior thyroid veins if you go too low and you're below the cricoid on the trachea or the isthmus.
Right.
Which is why staying strictly within the CTM boundaries is absolutely vital.
And strictly midline.
Strictly midline. If you deviate laterally, what do you hit?
The cricothyroid muscles.
And what's the problem with that?
Well, it's going to be bloody, for one, but that's also the tensor muscle for the vocal cords.
Yeah.
If you damage that, you could alter the patient's voice pitch permanently.
Exactly. BD Charesia also mentions the external laryngeal nerve is nearby.
Oh, right.
The external branch of the superior laryngeal nerve supplies that muscle. It runs deep to it, but, inflammation or a very wide dissection could theoretically endanger it.
I see.
But let's be honest.
Yeah.
In a cannot oxygenate situation, bleeding is a secondary concern to death, and voice changes are a very distant third.
Life over voice. I like that as a mantra. Okay, what else? What lies behind the trachea?
The esophagus.
The esophagus. It lies immediately posterior, so if you stab too deep, you could get a through-and-through puncture. You've just created a tracheoesophageal fistula with a scalpel.
Which is
not ideal.
Definitely not. So for the examiner, what are the two key anatomical landmarks you must mention by name?
The thyroid notch and the cricoid ring.
Good. And the technique of identifying them?
The laryngeal handshake, stabilizing the larynx with one hand while identifying these landmarks with the other.
Excellent. The physical manifestation of that anatomical knowledge.
Yeah.
Now let's move on. Part C, indications. Why are we even doing this?
So the primary indication is CICO. Cannot intubate, cannot oxygenate.
Define that for me. What does it mean?
It means that mask ventilation has failed, a supraglottic airway like an LMA has failed, and tracheal intubation has failed. All non-invasive options are off the table.
And the textbooks?
Milla and long and short cases are very clear. This is the definitive rescue.
Is it only for failed intubation?
No, it's also for a primary upper airway obstruction.
Yeah.
A situation where you can't even try to go in from the top.
For example?
Massive facial trauma. A smashed face injury where the oral and nasal routes are just blocked by blood and bone, or severe angioedema like Ludwig's angina, where the tissues of the tongue and glottis are so swollen you can't see anything.
Correct. Or a foreign body that's impacted at the glottis. A piece
Yeah.
of food, for example. Now imagine you are in the Viva. The examiner leans forward and asks, "Candidate, give me a one-sentence definition of the indication." What do you say?
I would say, sir, the indication is the immediate need for an airway when all non-invasive methods have failed.
Good. Concise. To the point. Now, the trap question. What are the contraindications? Is there any time you would never do a surgical cricothyrotomy?
Yes, the age limit. In young children, specifically under, say, 6 to 12 years, depending on the text.
Let's use a safe number. Prepubertal.
Okay, prepubertal children. Surgical cricothyrotomy is contraindicated.
Why? This is the why question that gets you the distinction. Tell me the pathophysiology.
It's because in young children, the cricoid cartilage is the narrowest part of the airway, not the glottis, like in adults. And the membrane itself is tiny, way smaller than that 9 millimeters we talked about. It's too small to accept a tube without completely destroying the cartilage ring. Miller is very specific about this. It says, for them, you have to do a needle cricothyrotomy.
Correct. It is a bit of a gray zone because children grow at different rates. Miller suggests 6 years is a hard cutoff. Morgan sometimes references 10 or 12.
So what do I say in the exam if they give me an age like 8?
Acknowledge the controversy. That shows advanced understanding. You say, "Sir, in an 8-year-old, the anatomy is transitioning. I would need to assess the size of the neck. However, the needle technique remains the safer initial choice to avoid the devastating complication of cricoid damage."
That sounds very nuanced. Examiners must love that.
They do. It shows you aren't a robot repeating facts. You're a clinician weighing risks. What's the other absolute contraindication?
Laryngeal fracture. A smashed larynx.
Why?
Because if the larynx is already fractured, digging around in the CTM could cause complete laryngotracheal separation. You could effectively avulse the entire airway.
You pulled the two ends apart. It's an unsurvivable injury in that setting. In that case, you might need a formal tracheostomy or to go in below the site of injury.
That makes perfect sense. So let's talk about where this fits in the algorithms. The Difficult Airway Society, the DAS guidelines, they're the Bible for this, right?
They are. In the DAS guidelines, where is this?
It's Plan D, the last resort.
Walk me through the plans.
Okay, so Plan A is intubation. That's your primary goal, if that fails.
After a reasonable number of attempts.
Right. Not endless attempts. Then you move to Plan B, which is a supraglottic airway device like an LMA to try and rescue oxygenation. If that fails, Plan C, wake the patient up. Go back to face mask ventilation if you can. Abort the procedure.
Well, what if you can't? What if you can't mask ventilate them and you can't wake them up fast enough?
But then you're at Plan D, CICO rescue, cricothyrotomy.
Right. And Miller discusses the Vortex approach, which is a really great visual. You have these 3 lifelines: face mask, tube, LMA. If one fails, you spiral inwards. If they all fail, you hit the center of the vortex.
Which is CICO rescue.
Exactly. The key for the exam and for your clinical practice is that transition. When do you move from Plan C to Plan D? When do you decide to cut?
When the patient is becoming hypoxic and you cannot wake them up, you have to declare it. I think that's the examiner safe point. Stressing the importance of declaring CICO out loud.
Yes.
You don't just keep trying to intubate a hypoxic patient. You have to announce to the team, I cannot intubate, I cannot oxygenate, we are proceeding to a surgical airway.
That's it. Decisiveness is a markable quality in the Viva. It shows leadership and a clear thought process under pressure. Now, Part D, the meat of the matter. Types and techniques.
Okay, so we have, 3 main flavors here. Needle cricothyrotomy, surgical cricothyrotomy, and then the percutaneous or Seldinger techniques.
Let's break them down. Differentiate needle from surgical for me. What's the core difference?
Needle cricothyrotomy uses a wide-bore cannula, something like a 14-gauge or 16-gauge IV cannula. It requires a high-pressure gas source, which we call jet ventilation.
But there's a big but.
But, and this is the huge distinction, it is a temporizing measure. It only buys you time, maybe 30 to 45 minutes, because you can't effectively blow off CO2 through that tiny needle.
Correct. It oxygenates, but it doesn't ventilate well. Carbon dioxide accumulates, leading to a severe respiratory acidosis. What about surgical?
Surgical cricothyrotomy uses a scalpel and a small cuff tube, usually a 6.0 millimeter internal diameter tube. This is considered a definitive airway.
Like definitive.
Because you can ventilate properly, you can scrub CO2, and the cuff protects the airway against aspiration.
Good. And the percutaneous or Seldinger technique.
That's using a guide wire and a dilator, like a Milker kit. Miller notes that while we anesthetists are comfortable with this because it feels like putting in a central line.
Which we do all the time.
Right, but it can actually be slower than the scalpel technique in a true crisis. Fiddling with wires and dilators when a patient is turning blue is stressful and prone to error.
It is. That's why the DAS guidelines have shifted. They now heavily recommend the Scalpel-Bougie technique. This is an exam favorite. If they ask you for the steps of a surgical crico, this is the technique they want to hear.
Okay.
Walk me through it, step by step.
Okay. Step 1, position. You extend the neck to bring the airway forward, unless, of course, there's a suspected C-spine injury.
Good. Step 2.
Identify. Palpate the CTM. Use the laryngeal handshake we talked about. Stabilize the larynx.
Step 3, the scary part.
Incision. Make a horizontal stab incision through the skin and the membrane.
At the same time.
Yes, simultaneously. One decisive movement. Just go for it.
Step 4. This is a crucial, often forgotten step.
The twist. This is critical. You rotate the scalpel 90 degrees, and the sharp edge should be facing caudally towards the feet. This holds the hole open.
Let's pause there. I want to really visualize that twist. I've heard people ask, why not just put the bougie in through the slit? Why do we need to rotate the blade?
Well, you have to think about the tissue. The CTM is elastic, like a rubber sheet. You make a horizontal slit. The moment you remove the pressure, that slit just wants to close up. If you try to push a soft, flexible gum elastic bougie against that closed slit, it might just bunch up, or worse, create a false passage in the subcutaneous tissue.
Exactly. The twist turns that linear slit into a triangular or square opening. It physically levers the cartilages apart slightly and creates a patent hole. You can often hear a gasp or a hiss of air immediately.
So it confirms you're in, too.
And it creates a clear, open path for the bougie to slide down alongside the flat of the blade.
Right, because if you take the scalpel out to put the bougie in, you've lost the hole. You'll never find it again through the blood and the panic.
Precisely. The blade acts as a guide and pointing the sharp edge caudally. Why is that detail so important?
It's for safety. If the patient bucks or your hand slips and the sharp edge is pointing up, cephalid, you could cut the vocal cords.
A disaster.
But if it points down, caudal, you just cut into the tough cricoid ring. It's cartilage. It'll stop the blade.
That is a critical examiner-safe detail. Sharp edge down. Okay, you've twisted. Step 5.
Bougie. Slide a gum elastic bougie down the side of the blade into the trachea. You should feel for the tracheal clip.
We'll come back to that. Step 6.
Railroading. You slide a lubricated 6.0mm cuff tube over the bougie and into the airway.
And the final, most important step.
Step 7. Confirm. Inflate the cuff, check for chest rise, and most importantly, get a waveform on your end-tidal CO2 monitor.
The ab, twist, bougie, tube. Memorize that sequence. In the exam, use active verbs. I will stab, I will twist. It shows confidence.
Got it. Now, can we loop back to the needle technique? You mentioned jet ventilation. That seems like a high-yield Viva topic.
That is, how do you do it?
You insert a 14-gauge cannula at a 45-degree angle, pointing caudally towards the lungs. You confirm you're in by aspirating air bubbles in a saline-filled syringe. Then you connect it to a high-pressure source.
Oh, wait. Morgan adds a very specific detail here about confirmation. Do you just aspirate once?
No. Good point. You aspirate air when the needle tip enters the trachea. Then you slide the plastic catheter forward off the needle. But you must aspirate again after the catheter is in place.
And why is that double check so critical?
Because it's a very common failure point. You might hit the trachea with the needle tip, great, you get air, but as you slide the plastic catheter forward, maybe the needle was barely in. The catheter catches on the cartilage or pushes the membrane away.
And where does it end up?
In the subcutaneous tissue. The needle is out, you think you're in, you hook up the jet ventilator, and you inflate the patient's neck instead of their lungs. Catastrophic subcutaneous emphysema.
So the sequence is puncture, aspirate, slide catheter, aspirate again. Only then do you connect the jet. That double check is a Viva gold star right there.
Okay, that's burned into my brain now. What about the pressure? What pressure do you need for jet ventilation? It's high, 50 psi, pounds per square inch. You need that driving pressure because the cannula is so narrow.
And where do you get that from?
You can use a dedicated device like a Sanders injector, or you can use the oxygen flush valve on the anesthesia machine, often with some self-made tubing.
Let's expand on the physics of jet ventilation. The classic teaching was about the Venturi effect, wasn't it? That the high-velocity jet entrains room air. Is that what's happening in CICO?
Actually, Miller clarifies this. While that's true in an open system like rigid bronchoscopy, in a CICO situation with a narrow 14-gauge needle and a potentially obstructed upper airway, the entrainment is minimal.
So what's the main mechanism?
It's just high-pressure mass flow. You're just blasting oxygen into the lungs to keep the sats up. It oxygenates, but it doesn't ventilate.
Good. And the IE ratio, inspiration to expiration time.
Inspiration has to be short, 1 second on, but expiration needs to be long, 3 to 4 seconds off.
Why? This is the most critical Viva point about TTJV.
Yeah.
Why the long expiratory time?
Because expiration is passive. You're pushing air in under high pressure through a tiny hole, but the air has to get out through the patient's natural upper airway, through the glottis. It can't come back out the needle efficiently.
Precisely. Which leads us to the absolute contraindication for transtracheal jet ventilation.
Complete upper airway obstruction. If the glottis is totally blocked, the air goes in, but it can't get out. You just start stacking breaths. The pressure builds and builds in the lungs until massive barotrauma and bilateral pneumothoraces.
Excellent. If the plumbing is blocked at the top, do not pump from the bottom. Remember that.
Got it. Okay, moving on to Part E anesthetic considerations. What are we, the anesthetists, doing while all this cutting and jetting is happening?
Well, oxygenation is priority number one. 100% oxygen immediately. What about drugs?
If the patient is arresting or unconscious, which is very likely in a CICO scenario, you don't need any drugs. You just need the airway. Now.
And if they're not? If they're awake or struggling?
Then the ICU book mentions ketamine as a good choice. It preserves respiratory drive. Or if you're converting to a surgical airway in a semi-controlled way, you might use a rapid sequence induction agent.
Why ketamine specifically? Why not give a slug of propofol?
Oh, because propofol causes apnea and a total loss of airway tone. If you have a patient who is maintaining their own airway gasping but moving some air, and you give them propofol, their airway completely collapses.
Yep.
Now you have a total obstruction where you had a partial one. Ketamine is a dissociative anesthetic. It provides analgesia and amnesia, but the pharyngeal and laryngeal reflexes often remain intact, and crucially, spontaneous respiration continues. It allows you to operate on the neck while the patient keeps trying to breathe.
What about muscle relaxants? Raycoronium.
This is controversial, and it depends on the guidelines you follow. In a true CICO, where laryngospasm might be the cause, a dose of muscle relaxant might break the spasm and allow you to ventilate.
So the DAS guidelines.
The DAS guidelines generally suggest ensuring the patient is fully paralyzed before you declare a failed intubation, just to rule out inadequate relaxation as the cause. So the sequence is ensure paralysis, try to intubate, fail, try LMA, fail, mask, fail. Then you declare CICO and you cut.
That is the sequence. But if you are doing a primary cricothyrotomy, say on an awake patient with that smashed face we talked about, you would avoid paralysis. You want them breathing until that tube is in and secure.
That's a key distinction. Rescue CSO versus primary emergency airway. What about local anesthesia?
If time permits, which it rarely does in a true CICO crisis, you can infiltrate lidocaine with adrenaline to reduce bleeding. But honestly, as we said, in a cannot oxygenate situation, you just cut.
Right. Speed is everything. Okay, confirmation. How do you know the tube is in the right place?
Clinical signs first.
Chest rise, misting in the tube. But the
No.
gold standard, the one you must mention, is capnography. You want to see that square wave ETCO2 trace on the monitor.
Why not just auscultation? I will listen to the chest.
Examiner safe answer. In a noisy trauma room or a chaotic resuscitation, auscultation is completely unreliable. You can hear sounds everywhere. You have to rely on capnography and direct visualization of chest rise.
Good. Now, Part F, complications. You saved the life, but what mess have you potentially made?
Well, there are immediate and late complications. Immediate would be hemorrhage from the thyroid vessels or even the jugular veins if you deviate too far laterally.
And what about air?
Subcutaneous emphysema. If the tube is placed in the pretracheal tissue, a false passage, you're just pumping air into the skin, it causes that Rice Krispies crackling feeling on palpation.
Let's talk about that false passage. How do you know in the moment that you've made one?
The tactile feel might be different, but clinically, you place the tube, you inflate the cuff, and you try to ventilate. And 1, the chest does not rise. 2, the end tidal CO2 trace is flat. It's 0. 3, the neck starts to swell up like a balloon.
That is a terrifying triad of signs. What do you do?
You have to pull the tube out immediately. You are not in the airway. You are in the pretracheal space. You need to repalpate, restab, Or, more likely, extend your incision so you can visualize the trachea directly.
This is why the bougie is so important.
Yeah.
It gives you that tactile confirmation. You mentioned it earlier.
Feeling the tracheal clicks.
Yes. As the bougie goes down, you can often feel the tip bumping over the cartilaginous tracheal rings. It's a very distinct sensation. If you don't feel clicks, or if the bougie stops after just a couple of centimeters.
It's in the wrong place.
It's in the wrong place. Or it's hit the carina, the hold-up sign. If it goes down a bronchus, it will also stop. But if it's in soft tissue, it might just feel mushy or keep going indefinitely.
And if you go too deep with the initial stab.
Esophageal perforation.
Yeah.
And the big one with jet ventilation that we already covered.
Barotrauma and pneumothorax.
Now, late complications. This is what the ENT surgeons will be worried about later.
Subglottic stenosis. The ICU book states this is the most feared long-term complication, and the risk is very high if the cricothyrotomy tube is left in for too long.
Why is it so bad there?
Because the cricoid cartilage is a complete ring. It's the only one in the airway. So inflammation and scarring there can lead to a fixed narrowing of the airway that is permanent and very difficult to treat.
And voice changes.
Yes, damage to the cricothyroid muscle or the recurrent laryngeal nerve can affect the quality and pitch of the voice.
So how do we manage these complications?
Immediate recognition is key. If you see that subcutaneous emphysema spreading, stop ventilating immediately. If there's significant bleeding, you pack it. But the real management is prevention and conversion.
Which leads us perfectly to Part G, post-procedure care. You've done the crico. The patient is alive. The sats are up. What do you do now?
First, you have to secure it properly. Suture it in place. Use ties. Don't let it fall out. But then you immediately need to plan the exit strategy. You need to convert to a definitive airway.
What is the time frame for that conversion?
Both Miller and Morgan suggest converting to a formal tracheostomy within 24 to 72 hours. You want to get that tube out of the CTM as soon as the patient is stable enough for the procedure.
And the reason is?
To minimize the risk of subglottic stenosis and cartilage erosion.
Correct. Remember our phrase. It's a temporary bridge. You cross it, then you build something more permanent. Also, remember the ICU care. You've bypassed the nose and mouth. What do?
They are the body's natural humidifiers and filters.
Exactly. Now you are blasting dry, cold gas directly into the trachea. What happens?
Crusting. Thick, tenacious secretions.
Massive crusting. The secretions can dry out and form concrete-like plugs. You can obstruct your life-saving airway within hours. So what is mandatory immediately post-procedure?
Heated humidification and regular diligent suctioning.
Absolutely. And what about sedation?
You would generally want to keep them heavily sedated. Having a tube through your cricothyroid membrane must be incredibly irritating. It would trigger the cough reflex constantly.
And you don't want the patient coughing the tube out or causing more trauma to the site.
Makes sense. Okay, Part H. This is about comparison and exam integration, bringing it all together.
Let's do a rapid-fire comparison. Crico versus track site.
Crico is the CTM. Track is the second to fourth tracheal rings.
Seed.
Crico is 1 to 2 minutes. Track is 15 to 30 minutes.
What are you going to risk?
Crico is low, it's midline, and relatively a vascular membrane. Track is higher, the thyroid isthmus and a plexus of veins are right in the way.
Long-term use.
Crico is contraindicated long-term. Track is suitable for maintenance and long-term airway access.
Excellent. Now let's talk about Viva traps. These are the questions designed to trip you up. We already mentioned the age trap.
Right. Would you perform a surgical cricothyrotomy on a 3-year-old? The answer is an emphatic no. Needle cricothyrotomy only.
What about the delay trap?
When should you cut? The answer is not after 10 minutes or when the SATs hit 50. The answer is as soon as CICO is declared. The delay is what leads to hypoxic brain injury.
Precisely. And the landmark trap. What if the patient has a short, fat neck or massive edema and you cannot feel the membrane?
This is the nightmare scenario. The book answer is you have to use a vertical midline incision to dissect down. You cut through the fat and fascia until you can physically feel the cartilage with your finger.
And ultrasound.
Miller does mention ultrasound, but in a true CICO crash, you probably don't have time to go get the machine, turn it on, find the probe. You just have to cut to feel.
Cut to feel. That is a brave but necessary answer for the exam. But what about using ultrasound before the crisis?
Oh, in an anticipated difficult airway.
Exactly. Tell me about that.
So if you have a patient with, say, a huge goiter or distorted anatomy from previous surgery or radiation, but you are planning a standard intubation.
You're worried but hopeful.
Right. You can use ultrasound to identify the CTM and mark it on the skin with a pen before you even put the patient to sleep.
That's brilliant. So if everything goes south and you end up in a CICO situation,
You have an X that marks the spot.
it shows incredible foresight. If you mention that in an exam answer about management of the anticipated difficult airway, you will score very, very highly. It mitigates the landmark trap. You don't have to find it through the panic. You found it while you were calm.
Pre-procedure ultrasound marking of the CTM. Adding that to my notes. Finally, for the exam presentation itself, if you're asked to draw this.
Always start with a definition. Then anatomy boundaries, contents, relations, and you must draw the diagram. A simple square showing the thyroid cartilage, the cricoid, and the membrane in between. Draw the cricothyroid arteries running across the top half, and then label safe zone in the bottom half.
Diagrams actually get marks.
Diagrams save you time and they get you marks. A bad drawing is often better than a good paragraph because it shows you understand the spatial relationships. Then list your indications and contraindications. Then the step stab, twist, bougie tube. Then complications. Then your conclusion.
The conclusion we drafted was, cricothyrotomy is a life-saving, albeit temporary, procedure that demands precise anatomical knowledge and decisive action. Mastery of the CICO algorithm and the Scalpel-Bougie technique is mandatory for every anesthesiologist.
That is a consultant-level conclusion. Memorize it. Use it.
Okay, so let's summarize for everyone. Give me the bullet points for the listener who might be driving to their exam right now. The absolute must-knows.
All right. 1. Cricothyrotomy is an emergency rescue procedure, not a permanent airway.
The anatomy is the CTM, the soft spot between the thyroid and cricoid cartilages.
The technique of choice in the UK and increasingly everywhere is the Scalpel-Bougie tube technique.
The main long-term complication to fear is subglottic stenosis.
You must convert to a formal tracheostomy, usually within 24 to 72 hours.
Perfect. So expert, before we sign off, what is your single final piece of advice for the exam day when the examiner stares at you and asks about airway emergencies?
In the Viva, when you're asked about an airway emergency, the most important thing you could do is take a breath.
Yeah.
Don't panic and ramble.
Yeah.
Structure your answer. Say, first, I will call for help. Then, I will optimize oxygenation. If that fails, I will declare CICO and I will cut early. Confidence saves lives. And confidence passes exams.
Declare CICO and cut early. I will remember that. And for our listeners, I would say visualize that anatomy on your own neck right now. Find the dip. Feel the ring. That tactile memory might just save a life. Or your exam results one day.
And remember, everything we discussed today is based strictly on standard medical texts like Miller, Morgan, and Chirasia. Stick to the books, and you will be safe.
Thanks for joining us on this very high-stakes deep dive. Good luck with the exams. We'll see you next time.